Hi, everyone. It's Dr. Sadaf, and I'm so excited to let you know about a free webinar I am hosting on August 25th at 7 p.m. Eastern Time. It is going to be on menopause for men. Yes, you heard that right. Menopause for men. How a man or a partner can support their partner during midlife. So really important information. I get a lot of questions asked to me by people coming in and saying that, they're learning about menopause, but their husbands don't know and they don't know how to support them. And they just feel like they're being, angry and irritable on purpose, which of course, maybe that's part of the thing, but not really. But they would like some information that their husbands could learn from. And so I am doing this webinar just for your partners. And of course, you're welcome to join in and listen in if you find it to be valuable. It's going to be valuable. It's going to have a lot of good information. But the key thing that I'm going to focus on is how your partner can support you in midlife. So remember, it's going to be August 25th, 7 p.m. Eastern. I'll have the link in the show notes for you to register, but also it'll be on my social media. My social media handle is at Dr. Sadaf OBGYN on both Instagram and TikTok. And on YouTube, it's the Muslim Sex Podcast and Fembe Health. So make sure you look out for all of those registrations and make sure you register for August 25th, 7 p.m. Menopause for Men. And see you there. I'm an American board certified OBGYN, a mom, a Muslim, and I'm talking about sex. This is the Muslim Sex Podcast. Welcome to the Muslim Sex Podcast. I'm your host, Dr. Sadaf Lodi, and this episode is everything you need to know about hormones, sex, and aging. But before I get into it, a few things I want to make very clear is this is not any medical advice. So if you have any questions about hormones or sex or aging or any of that, make sure you go speak with your healthcare provider. If you have any questions about your religion, make sure you go speak with your friendly neighborhood religious leader. This is the Muslim Sex Podcast because I just happen to be a Muslim woman that talks about sex. So I am super excited to have on with me today my guest, Dr. Tami Rowen, coming to us all the way from the Bay Area in California. So Dr. Rowen, welcome.
Thanks so much for having me.
Yeah. So for those people that may not know who you are, if you could introduce yourself, that would be great.
So I'm Tami Rowen. I'm a board certified obstetrician and gynecologist. I'm currently an associate professor at the University of California in San Francisco, where I have basically spent my entire career. I did my medical school training, my residency, and then I stayed on as faculty. And my main area of clinical focus really is sexual medicine, but that kind of has taken on a very broad category of things, basically. So I am kind of UCSF's both sexual medicine expert as the director of their sexual health program. I'm also their menopause lead. Clinician. I also have expertise in vulvar care, sexual pain, and then I have a pretty niche focus in surgery. So I'm the medical director of perioperative services for the OBGYN department. So I perform probably the most surgeries in our department, and my clinical focus in surgery really is in vaginal and vulvar surgery. So I do a ton of vaginal hysterectomies, for example, a lot of vulvar labial surgeries as well.
That's amazing. That sounds like a lot of stuff. How do you even time? Surgery itself takes up a lot of time. And then sounds like you're doing so many other things with, sexual medicine and menopausal medicine. Really amazing. Do you have a team with you?
Not really. I'm kind
You're
of
a team of one.
a team of one. I have I have fabulous colleagues that I work with, other clinicians. I have some nurse practitioners that I work with that can help with some of my patients as well. But no, I don't really have a team under me. It's really me. Yeah.
Wow. Well, that is even more amazing. So I'd love to get into it a little bit. So you've done, all of your work sounds out of UCSF around hormone therapy and sexual function. And what do you think drew you toward this? Because I know, and I'm not sure about your training, but I didn't get anything. I didn't get anything on sexual medicine, didn't get anything on menopause care. So what drew you to sexual medicine and menopause?
So it's really kind of a lifelong story, I would say. I mean, I grew up, and this may be different from you and some of your listeners and other people, and I find how we grow up very fascinating. I grew up in a very sex positive family, and so
Amazing.
sex was just something that was talked about in a very positive way. My grandmothers, my grandmother told my now husband the first time she met him that the most important thing in a relationship is good sex. And
Amazing.
I actually asked my mom as a kid, how important is sex in a relationship? And she said, this, my mother told me it was 100%. And that's not to say there's not other important things, but what she meant to say, and she explained it, and I feel this way very much, and I'm sure we'll talk about it, is that when you have a good sexual relationship, you put up with a lot. And it really helps to give you patience. And that's really what you need and understanding in your relationship to have a good relationship. And so that always kind of stuck with me. I taught a sexual health class or female sexuality class as an undergrad at Berkeley, which you can imagine what that was like back then in undergrad. It's kind of a scandalous class.
Yeah.
And then how I got into it professionally is actually really by accident. I went into OBGYN because I wanted to be a family planning person, and I still am. So I really wanted to help people have the types of families and family sizes that they wanted.
Right.
And that was always my goal. And then I met somebody when I was a medical student who was a urologist, and he introduced me to the world of sexual medicine. And I realized there was all this research on male sexual medicine, and there was this emerging field of female sexual medicine. And I started going to conferences and I started doing research. And that person and I ended up having a professional and personal relationship. He's now my husband and the father of my 3 kids.
Oh, okay. Well, that was beneficial.
And he was really, he doesn't, it's always awkward when you give credit to someone else, right? But it really was him opening my mind to this. And when UCSF was looking for a new faculty member, they hadn't hired in years, and I was going to go into family planning. It's a very long story. They interviewed me and were curious what I could offer them. And I looked around and I said, no one is taking care of patients with sexual problems. And I had done also some work on the side in cancer survivorship. I have a lot of interests, as you can tell. Everything about OBGYN excites me. And so I had done all this work with cancer survivorship. I also had a background in disability studies, and I was very interested in people with disabilities. And I essentially said, I'll see all the patients that you don't want to see, was really
Wow.
the underlying thing. And they gave me the job. And it's
Yeah.
been a supportive institution. And if they're going to give me the opportunity, I'm going to run with it. And so that was it. It was really by accident. It had to do with a kind of host and series of events.
Amazing. Well, that sounds phenomenal. So I know that there's, so much confusion around hormones and midlife, and we know that estrogen, progesterone, testosterone all go down during perimenopause and menopause. Maybe you can just help our listeners to just kind of understand what impact that has on the body and the brain.
So I think that the thing that's really important to understand is that every single cell in the body has receptors. Well, I don't want to say every cell. The majority of cells in the body are actually sensitive to hormones. And we don't think about that. In OBGYN, we talked about the fact that we didn't learn any of this in our training, right? So almost everything that you and I both know, we learned later. And we've learned through really conferences and reading and looking at data and studies. And it's really this emerging understanding that hormones influence so many aspects. And we know it, in utero, we knew that. We knew it in menarche. We know it in our reproductive years. And really, the last frontier is what does it mean in our post reproductive years, right? As the hormone levels go down. And so, because so many tissues are sensitive to hormone, we could spend this entire show talking about
Yeah.
all the ways and all the systems. And I'm sure you've talked about it in other episodes. In terms of what happens, we know that the brain is sensitive to hormones, the skin is sensitive to hormones, the heart is sensitive to hormones, the gut is sensitive to hormones. So I can pick one of those and elaborate on it or explain
Yeah.
that you can
Yeah.
only imagine as hormones go down, they're going to really alter those parts of the body.
Yeah, absolutely. So I know that there's still a lot of research going on about the gut. I don't hear about the gut as much, but definitely, the brain and we know the hair, the skin. I mean, like a lot of women come in, right, with hair loss in perimenopause and menopause. We see the weight gain. That's, I think, one of the most distressing things that women come in with during perimenopause and menopause, and don't understand that redistribution of fat that occurs due to the decline in estrogen. Of course, we know about the brain fog. I just had somebody yesterday. She came in, she's 59, and she's just, she has like a history of depression and suicidal ideation. And she noted that in perimenopause, and nobody made that connection for her. She said that she was the most suicidal while she was going through perimenopause, and she didn't understand why. And then now in menopause, she finds that it's gotten a little bit better, but she has to keep adjusting her psychiatric meds. But she said the estrogen has made a significant impact.
That's actually really interesting. So, I would say I think the brain functioning, it's not just mood, right? There's lots of ways that the brain processes and neural processes are modulated by hormones. I think one of the misunderstandings is neurons don't talk to each other via hormones. They talk to each other via neurotransmitters,
Yeah.
right? So there's really molecules or chemicals that are spread or distributed from one neuron to another in the brain. Those are the brain cells, basically. They're modulated by hormones. And when we think about the mood neurotransmitters, that's when we talk about things like serotonin, dopamine, norepinephrine. Those are the neurotransmitters that really play a pretty strong role, both in mood as well as in libido, as
Yeah.
well as in anxiety, And so the way that hormones affect the neurotransmitters and how they are regulated and I would say interpreted by different brain cells is getting more clear in understanding. What I think is really the issue that comes up in menopause and perimenopause is this question about estrogen versus progesterone. And I can talk about progesterone all day long because progesterone is a fascinating hormone. And in perimenopause, what we see is not that estrogen is declining. I think there's a misunderstanding. I've always described the ovaries as sputtering cars, or it's a sputtering engine in perimenopause. And it's just like spitting out hormone. And so the highest levels of estrogen you're ever going to see are going to be in perimenopause. And when I was younger in my training, I would get these lab values for patients. And I'm not someone who is on the side of recommending hormone labs in perimenopause for this reason, because you're going to catch the highest levels and the lowest levels, and they're not really meaningful, right? It's sputtering it out. And it's the fluctuation that's causing so many of the symptoms, right? Hot flashes are not estrogen deficiency. If they were, people's hot flashes would be far worse the older they get. They're the worst in the menopausal transition, and it's because of the fluctuations, right? So you get really high and you get really low. What doesn't do that is progesterone. Progesterone is declining, and progesterone is the hormone that's made during ovulation. XX individuals are the only people that have it. I think it's my favorite hormone, and it is only made in ovulation. So testing for progesterone in perimenopause is also not very helpful because one of the hallmarks of perimenopause is anovulation. You're not ovulating, but if you do ovulate, your progesterone levels are going to be low. And that is the place where I do see sometimes supplementing with progesterone really does improve mood symptoms. Whereas premenopause in younger people who have mood symptoms related to their period, progesterone is not the answer. It's oftentimes it makes things worse. And so the perimenopause is this really unique time where I wonder more about both the estrogen, but also what's happening to progesterone in terms of the neurotransmitters and mood symptoms.
That's so interesting. So, do you think that for somebody that is suffering from, let's say, anxiety, like new onset, right? So, we know that in perimenopause, women can develop new onset anxiety and depression. Even those that have never had it before can develop it. And that's really interesting that you would say that about progesterone. Do you think that, so we add, typically we'll give like estrogen and progesterone, but I'm wondering and I'm curious, do you think that a higher dose, maybe like something that, if we give like micronized progesterone, like say like, would you do something like a 300 milligrams? Have you ever done that? Do you go that high, or do you not?
Not necessarily. I'd be a little bit worried about the neurosedative side effects. So, I think what I do when someone's coming in with mood symptoms is I take a really detailed history about both their menstrual cycle and their mood symptoms. And I try to match, if they are ovulating, where in the ovulatory cycle are their symptoms occurring? And based on that, I can kind of map out where I think the hormone fluctuations that could be contributing. Now, one thing to remember is a lot of times what we're doing nowadays is saying everything is hormonal. It's really easy to say this is all about hormones, and it's not, right? Some things, some people have cyclic mood symptoms, and if you suppress their cycle and they're not having any ovulatory cycle, they still have cyclic symptoms. It's not hormonal, right? They're just cyclic mood symptoms. And there's a lot of things that can go on, in perimenopause and menopause that are not necessarily hormonal that we might attribute to it. But if I do think this really is hormonal, I figure out what's happening to the hormones that could be triggering it, and I manipulate based on that. So if somebody's symptoms really start in the day or two before their menstrual cycle, that is not a progesterone sensitivity. That is likely due to the drop in estrogen and progesterone. And the biggest question is, when does it get better? Because for most people, it'll get better a day or two into their cycle. And what hormone is starting to increase then? Estrogen, not progesterone. So for those patients, I might give them just some estrogen to tide them through that drop, right, in the few days before their period and a few days after. If people's symptoms really seem to peak mid-ovulation, like mid-luteal phase, so a week after ovulation, if they're having pretty normal 28-day cycles, then I think I got a progesterone problem here. This person is sensitive to progesterone. What can I do to maybe have them not exposed to natural progesterone? But in perimenopause, if I'm going to give them, if they're anovulatory and they're having weird mood symptoms, and I think progesterone might be the answer, that's oftentimes where I'll start. I usually start with 100. You take it at night. It's not that progesterone makes people sleepy, it's that its metabolites do. So it metabolizes into neurosedatives. And that's when you take it with orally. If you place it vaginally, it doesn't do that. That's why people don't have the same kinds of symptoms. So if you're trying to help people sleep, don't give it to them vaginally, give it to them orally. But I wouldn't be giving them high doses necessarily, because I think orally, especially, they're going to get too sleepy. The only time you would do that is if you're thinking about helping with abnormal bleeding. But even then, I don't give natural progesterone for abnormal bleeding. I might be unique compared to some other people. Natural progesterone is really not that well absorbed at the level of the uterus. And so it would never be my go-to when people have weird bleeding patterns.
Hmm. It's so interesting, so fascinating. And so let's say somebody has like postmenopausal bleeding, right? They're on menopausal hormonal therapy. They've been on it for like 7 months. Their body has gotten used to it. At least you think it's gotten used to it. And all of a sudden now they start to have spotting, and they're on, just the estradiol and the progesterone. They were doing fine. And all of a sudden, you went up a little bit on their estrogen because you thought it might be helpful, but now they start to have this spotting, and you get an ultrasound. We know that, we always get an ultrasound, and maybe if they need it, an endometrial biopsy, and you get the ultrasound is like 2.7 millimeters or something like that, like less than 4. So you know that that's okay, but they continuously have this spotting. Would you increase progesterone in that scenario?
So that's a really great question. So, and again, it's always, I have to think about how do I bring this down to a more digestible level. So when somebody's bleeding, the question is, are they bleeding because of proliferation, or are they bleeding because of atrophy? So is the lining too thick, or is the lining too thin? And when you were talking about 2.4 millimeters, the way we think about that is that is so thin that it rules out cancer. So what we're most worried about when someone's bleeding is cancer. The most likely cause of postmenopausal bleeding is atrophy, and a 2.4 millimeter lining is consistent with atrophy. So adding progesterone to that doesn't, to me, make physiologic sense, because I'm not trying to thin this lining anymore, right? It's already thin enough, and it's probably just bleeding because there's some sort of imbalance in terms of how stable it is. The lining of the uterus wants to bleed. This is the family planning expert in me knows this very well, because this is very well established in the contraception literature, that the hardest thing about making contraceptive methods is trying to find a formulation that keeps people from bleeding. And so you have to stabilize the lining. You don't want it to get too thick, but you don't want it to get too thin. So in that scenario, I don't think adding more progesterone would actually make them bleed less, because their lining's thin enough. You're not blocking the effect of estrogen then. So in that situation, it may be that we have to play a little bit with their dose and route of estrogen, and it may be that we have to play with a different type of progestin, which I know is like, oh, we don't want to get away from the natural progesterone and estrogen, but sometimes we do for these symptoms, because the uterus is more stable, or the lining of the uterus is more stable in response.
Yeah, I'm curious to know what you think about, like, in that scenario that so let's say that you went up, she was on 0.05, you went up to 0.075, and that's when she started to have the bleeding. I wonder if you would consider, and but the ultrasound is thin, if you would consider, like, at that point getting like an estrogen level to see if she was absorbing or not.
Well, I think I would really be looking at her symptoms, right? Because I wouldn't be looking at the lining of the uterus. A 0.075 is still quite low. You're still going to have quite a low estradiol level systemic. It's going to be far lower than what a premenopausal woman would have. And so I wouldn't be, it would be very hard for me to imagine correlating the lining of the uterus thickness with a systemic estradiol level. I think you're going to find, if you took 100 women, you're not going to find significant correlation between those levels. Who are in postmenopause, because again, different people are going to absorb both the estrogen and the progesterone a little bit differently. I think what I oftentimes, would wonder is, if you get a 2.4, that this isn't cancer, could there be some sort of polyp that's hiding, like a 1 millimeter polyp that's doing it? Potentially. Polyps don't respond as well to progesterone, so sometimes they'll get stimulated. But in general, if I'm giving somebody more than a 0.05 patch, I'm going to want them on more progesterone anyways, just because natural micronized progesterone is so poorly absorbed. And so usually I would want to be seeing them more on a 200 dose, because I oftentimes do see both proliferation and abnormal bleeding if I give people less, 100 or less, and a 0.075 or a 0.1. But that's just my clinical practice. And I think that in the, there's different specialties, right? We're menopause people, right? In the fertility world, in REI, they are a little more skeptical. They use progesterone for pregnancy, but when it comes to menopause, they're a lot more skeptical, because progesterone is so poorly absorbed.
So interesting. You did this whole lecture at Ishwish, and it was on estrogen, and it was on the WHI study. And I just thought it was such an amazing lecture. I wonder if, I know it's, I know it's a very big topic, but I'm wondering if you could kind of talk a little bit about the WHI study. And, we know what it did for women. And, they had that whole FDA panel yesterday, right? That YouTube session with our colleagues on there, which is amazing. But just for those individuals that may not understand or know what that WHI study is, maybe you could just talk a little bit about it.
Yeah, so the WHI is the Women's Health Initiative study. It was actually a very large study. So there were multiple studies that were part of it. Over 100,000 women were enrolled in different aspects. So there was a diet study, exercise study, and then the one we talk about most in the menopause world is the menopausal hormone therapy study. And the background is that historically we know that women's risk of heart disease goes up to that of men's after menopause, right? We all know men in their 40s who had heart attacks. We don't know women, right? And so there's this and what's the difference, right? Estrogen, right? Estrogen goes away. So it's very biologically plausible that estrogen is providing cardioprotective benefits. And so historically, and retrospective data showed that. So historically, women were given estrogen therapy. And, the one thing we always knew estrogen did was stimulate the lining of the uterus, put people at risk of cancer of the uterus. And so to prevent that, we give a progestin. And that's very important because progestins are synthetic progesterone. I already talked about how progesterone is the hormone made after ovulation. It blocks the effect of estrogen. So if someone has a uterus, they need something to protect the uterus if they're going to be taking extra estrogen. So in the WHI, they started enrolling people in the 90s and they randomized women to either placebo or a combination of conjugated equine estrogen. So this was the kind of estrogen that was available. It's Premarin is the brand name. It's actually a proprietary blend of about 50 plus different estrogens. People don't realize this. No
Oh,
one
wow.
actually
Yeah.
knows what's in Premarin. It is
Oh,
not generic yet. So the history of Premarin is really interesting. I actually gave a lecture at ISWISH on this and kind of dove back, and I was like, there's multiple different estrogens. And I think this is actually important when we talk about the benefits that we're seeing in the WHI. We often talk about estrogen doesn't do X, Y, and Z. It's not. It's Premarin. This is a different molecule than natural estradiol. It's got a lot of different estrogens. It is stronger than natural estradiol. It is more potent than natural estradiol. It is taken orally. If women had a uterus, they took that medication in combination with a synthetic progesterone, a progestin called medroxyprogesterone acetate, aka Provera. So that in people who reproductive age people, we know that is Depo-Provera, right? It's actually the same medication. Depo-Provera is an injection that lasts for 3 months. Provera, it was a 2.5 milligram dose daily combined with the Premarin or the conjugated equine estrogen. That's one group. Another group that didn't have a uterus only took the Premarin because the rationale was they don't need any progesterone or progestin, and so just give them the estrogen. And the goal of the WHI was to look at cardiovascular events. It was designed, the sample size was designed, the recruiting was designed, everything was designed with the primary endpoint being cardiovascular disease and really events, heart attacks, MIs, right? So they randomized people according to cardiovascular risks, and they had thousands of people in this study. And the biggest issue with the study is that in order to find cardiovascular events, right, I just said we don't see women in their 40s with heart attacks. We barely see women in their 50s. If you're going to really see cardiovascular events, you need to be getting people who are 60s and 70s and starting them on these medications. And that's exactly what they did. So the average age of enrollment was 63. That is way older than most people we start on hormone therapy. And in the estrogen and progestin arm, they stopped it in 2002 because they had more heart attacks in the hormone group than the placebo group. And then in the estrogen group, they stopped it in 2004. And the initial data came out showing that hormone therapy increases the risk of cardiovascular disease. And then they did something more. They said it also increases the risk of breast cancer. The study was never designed to look for breast cancer as an outcome. If they actually, when they actually adjusted the models, it wasn't statistically significant. But the hazard ratio was 1.24 in the unadjusted models. And so they said there's a 25% increase in breast cancer. That sounds huge to people. It's not huge. If you look at the numbers, it was only in the estrogen and progestin group, and it was 8 per 10,000 extra women would have a breast cancer. And so that was just that group. So I can keep going if you want to ask questions about the problem with this study. But the next thing that finally came out was showing that if you actually just take away that group and only look at the estrogen, I would say the Premarin group, this is the key. It wasn't estradiol. It's Premarin. They actually had lower rates of breast cancer. And that's been shown now 15, 20 years. We now have more data coming out that the people that were just in the Premarin group all had lower rates of breast cancer. And even those in the estrogen and progestin group, they didn't have an increase in mortality.
Yeah.
And then the next thing that came out after everybody stopped taking their hormone therapy and we saw, huge spikes in all kinds of, you're going to see an increase in all-cause mortality without hormone therapy, is it turned out that the cardiovascular risk was only in the people who were 60 plus. When they looked at the people under 60 in both estrogen and progestin, and I can get into the details here, the progestin groups did worse. Provera is a bad drug. Provera is worse for the heart far more than estrogen is in older women. It was really the Provera. But even if we just say it was in the 60 and older, if you're under 60, those women had lower rates of heart disease. And even a bigger benefit if they weren't on Provera, if they were just on the Premarin alone. And so that my takeaway is that we now have randomized controlled data showing that it prevents heart disease if you take it less than 60. It doesn't cause breast cancer, but that's not how most people interpret the WHI.
That was amazing. That was so good. And I feel like I can just keep listening to you all day long.
I was
But
just let you ask questions and give shorter answers. So
I
sorry, I
know,
can keep talking. It's
yeah,
hard because
I
there's a
know.
lot of data to digest.
Yeah, no, it's fantastic, and I think it's so helpful for you to explain all of that, right? And also explaining, and I think you did this a little bit, but just maybe just quickly, just saying like the difference between a progestin and a progesterone.
Yeah, so progesterone is a 21 carbon molecule made from cholesterol. It's made in lots of different tissue. In women, it's mainly made in the ovaries, but it's actually made in like the spleen and the pancreas and adrenals. Like it's an interesting hormone, but mainly made in the ovary. It really only targets progesterone receptors. And so the way I think about hormones is there is basically a key and a lock, right? And so a lock is the receptor, and many different things can fit in it, right? And so different molecules are the keys. And so different molecules are going to fit in that lock differently. Progesterone is very specific to the progesterone receptor. The problem with progesterone exogenously, right? So we know progesterone's good in the body. It's great for the uterus. There's different cells that respond to it all over the place, but it's really hard to absorb. It breaks down very quickly. So natural progesterone you can't take. So we micronize it now, which breaks it down into kind of a smaller, more digestible molecule. But even then, it's not that well absorbed. And I already said it's not great at protecting the uterus. So this is why we have to think about our doses. Some people need higher doses than we oftentimes give, but there are synthetic forms of it. They look like progesterone. They're not, though, but they are basically a different key that fits into the progesterone lock, right? And they fit into it better in the uterus than taking exogenous progesterone. So they're stronger in the uterus at activating those progesterone receptors and blocking the effect of estrogen. The issue is that they also target other receptors. They're not like natural progesterone, which is specific, right? So Provera is a great example. Natural progesterone can actually metabolize into testosterone and estrogen, but it also can metabolize into glucocorticoids and mineralocorticoids. So those are your steroids, right? And so Provera acts like a steroid. It actually targets the glucocorticoid receptors. And that's probably why it makes people feel bloated. And we know that Depo causes weight gain, right? It's targeting other receptors. It's also when they study it in breast cancer cells, and they looked at different types of both natural progesterone and synthetic progestins. Natural progesterone doesn't seem to grow breast cancer cells in a lab. But if you put these synthetic progestins, especially Provera, it does. And so that makes sense that Provera was driving the increase, this tiny, right? 8 per 10,000, your risk of identity theft is higher than that. Tiny increase in breast cancer was driven by Provera. It's also cardiovascular effects are different. So natural progesterone, well, we know what natural estrogen does that it's a vasodilator. It relaxes the blood vessels. Provera constricts them. And so you saw higher rates of cardiovascular disease in people in both the estrogen and progestin in the WHI more than in the Premarin group alone. Does that make sense? Because this Provera is doing other things. Progesterone only acts on progesterone and then does these kind of beneficial vasodilating relaxation things. These synthetic progestins, not as good. There's a couple other synthetic progestins that we use oftentimes in birth control and a little bit in menopausal hormone therapy. They're not nearly as toxic, I would say, as Provera is, but they also have different properties.
So tell me a little bit about, how you help your patients make informed evidence-based decisions regarding menopausal hormonal therapy? I mean, I'm sure you don't have, especially being in an academic hospital, right? I'm sure what do you get, like 10, 15 minutes per patient? I mean, probably a lot, yeah, right? And you're
Yeah.
the only one doing it. So you probably got like a wait list of like a year. Like,
Well,
what the heck?
I will say there's other people. I have a lot of colleagues, and what's lovely
Okay.
is, the longer you're in OBGYN, the more interested you get in menopause because you kind of have to be. Your patients ask you. And
Yeah.
now it's getting very popular. So a lot of my colleagues are trying to do menopausal medicine, and they're doing a very decent job, I will say. The issue is it's hard to be up to date with all of this data, and there's so many different places people are getting information, right? So there's a lot in social media, that's out there. There's a lot that's coming out from kind of medical societies. There's a lot that people are hearing from their other providers, and other providers have a different interpretation and a different understanding of the data. So you'll hear me talk about data all the time, but I could look at the same study someone else could look at, and we'll come up with two different interpretations of it, right? So I get an okay amount of time, more than 10 minutes, for new patients, and follow-ups. But what I typically really try to get a sense of is what are the symptoms that people are most concerned about. I think a lot of times in menopausal medicine now, because I actually think it's easy, but it's not simple. And the reason I say it's easy is because you make people feel better so quickly, right? There's not, sexual medicine takes a lot of time, right? I have to do a lot of things to make people feel better, and they have to be very patient. Menopause is nothing like that. Their lives are so much better the minute you treat them, right? But figuring out the right treatment for them is a little bit more complicated. And so typically, I really want to know what symptoms are bothering them the most. And I want to be very realistic about what is menopause and what is not, right? A lot of things are not menopause. A lot of things are aging. And the reason that they're not menopause is because I can't hormone them away. All menopause is a hormone shift, right? If I can't hormone this problem away, it's not a menopause issue. And so
I love hormone it away. I love that.
yeah, that's
I'm
what
gonna
I
use
say,
that.
right? And so it's being really realistic. What are your primary what are your primary concerns? And so it's not, a lot of times people say, well, if their symptoms are mild, medium, or severe, then you dose them X, Y, and Z way. And it's like, no, no, no. What are the actual symptoms? And then I play around with, okay, what hormone do I think is going to do this, right? So if their main issue is sleep, I actually don't even give them. I will actually usually start them on progesterone if they can't fall asleep. I just give them natural progesterone. Let's just start there. If they can't stay asleep, that's where estrogen comes in. If their issue is weight gain, I can't hormone that away, and I have to be really realistic. And yes, fat distribution may change if I give them hormones, but weight does not. That has been shown in every single study. You cannot hormone away the menopausal weight gain, and so I have to be very realistic, about what that means and how to think about being healthy and fit. So really, that's kind of my approach. What are your symptoms? What are your goals? And then how do you take medication? Because there's a lot of different ways that you can give these medications, and they're not going to work if people don't use them. And so, everybody just wants to give everybody a patch, but that's not what everybody wants. Some people want a pill. Some people will do better with a vaginal ring. Some people will do better with a spray, right? And so that's oftentimes what I do. And I usually start, if I'm going to give estrogen, I start with estrogen alone, and then I add in progesterone later because I
Mm.
don't want to give them two things at once in case they have a side effect to one of them.
So that's so interesting because I remember actually, listening to Rachel say the same thing, that she gives one hormone at a time. But in my OBGYN brain, I'm thinking like, oh my God, I can't give unopposed
Yeah.
estrogen, right? And like I'm gonna cause this endometrial cancer, which we know takes like, a long time for it to develop. But like in my head, I'm like, I can't give estrogen without the progesterone. I gotta give both of them at the same time.
So I think that's a very reasonable approach. And I will say over the years, I have, been more keen to give people combined patches.
Mm.
I think typically we always say everyone should be on just an estradiol patch and prometrium, but I actually have a lot of patients who don't tolerate micronized progesterone. I think we need to be very realistic that it's not tolerated by everybody, and that a lot of times people don't want to be taking a pill every day. And I have diagnosed multiple people with endometrial hyperplasia and cancer because they felt good on their estrogen, and they're like, oh, why am I taking the progesterone? I'm not going to do this,
Mm.
right? Even if they were given it at the same time.
Yeah.
And then someone kept refilling their prescription. So, so I'm not, so I sometimes will give people the combined patch because I'm like, at least I'm getting you coverage. And then, sometimes we'll talk about whether or not I want to add on progesterone because I think progesterone is more than just a uterine protector. It's great for many things. If I'm going to give it to them separately, I don't give them refills. I give them a 3-month supply with 0 refills. And then I say, come back to me. You cannot continue this unless we try progestin or progesterone. Um, they're not going to get cancer in 3 months. They're not going to get cancer in 6 months. And so I do have 1 or 2 patients now where I'm experimenting with them, and their other providers are like, she gave you unopposed estrogen. And I'm not one of those people. I will never give anybody long-term unopposed estrogen. I'm not someone who's like, let's just get an ultrasound and monitor it or get endometrial. I don't believe in that. Those things don't prevent cancer. They diagnose it. I'm not going to give anybody something that will cause cancer. And I know estrogen alone does.
Yeah. Amazing. I'd love to get into just libido, right? So that's one of the things in midlife that we see a lot of people with hypoactive sexual desire disorder, where all of a sudden they start to get low libido, and we know that the testosterone starts to go down, but also like relationships change, right? And there's a lot of things that go on with libido, and it's not just a quick fix. I love how I'll have patients come in and they'll be like, "Well, my libido it's just not there. Can you just give me testosterone? Because I've seen on social media, we just get testosterone, and all of a sudden I'm going to be completely better." And I'll be like, no, that's not a quick fix, right? There's so many different components to libido. I'd love for you to talk a little bit about that.
Yeah, so in sexual medicine, we really focus on this idea of the biopsychosocial model, right? And I explain this to people. There is a biological drive to have sex. It is like sleeping and eating. This is how we reproduce, right? We know this. There are neurotransmitters and processes in the body that tell us to have sex. There is a psychological component, right? And so this is where we think about depression and anxiety in terms of how people body image, many things that play into our desire to have sex. And then there's the social component. That's our relationships. And so I usually explain that my job is to really tease out what I think is the main driver of their lack of libido. And if it truly does seem biologic, and I have, a couple tricks, that I can kind of figure out, some certain questions I ask that really get me there pretty quickly. But oftentimes it's not. It's exactly as you said. People come in and they're just like, well, I have a terrible relationship and I don't want to have sex with my partner. And I'm like, that will make someone not want to have sex. And they're like, but I don't have sex with anyone else either. And I'm like, having a bad relationship really affects lots of aspects of your life, and I've had patients come in and they're so depressed. I can feel depressed, just, depressed in their presence. And I'm like, this is depression. And testosterone, I think, it's a great medication. But the truth is, testosterone does not fall off a cliff in menopause. There's this idea that somehow in menopause now we suddenly need testosterone. Testosterone is not estrogen. It doesn't sputter and then suddenly run out. Testosterone slowly declines starting in your 30s. Right. And so it starts to go down and go down and go down. It's nothing significant is happening that different in, when you go through menopause. Your testosterone's been lowering for a long time. So if you are having sexual issues, they can absolutely be influenced by that decline, but it's oftentimes a combination of many other things. And so it's great to give testosterone, but it's not the end all be all in terms of fixes. And I want to be very realistic with people depending on their situation.
I love that. I love that because, we know that, libido is so complicated, right? It's not just a quick fix, and so many patients have issues with that. I just was talking to a patient right before this, and she was telling me how she's experiencing vaginismus, and she was having, a lot of pain, and she's not able to, it's been a year, she's not able to consummate her wedding. And it's, causing a lot of strife in her relationship. And she's like, now I just don't want to even have sex. And I said, I will quote you, Emily Nagoski. I said, Emily Nagoski, as we both know, is a sex therapist. And she says, to want sex is to have sex worth wanting, right? So if you're experiencing pain every time you have sex, why would you want that? And of course, it's going to affect your libido because you're not going to want something that's causing you pain. And if you have thoughts in your head that are telling you it's going to be painful, those muscles are going to tighten up and you're going to experience this pain with sex because of the vaginismus. So, really interesting. Like you said, you really got to do a deep dive and figure out why these patients are having this decreased libido.
Yeah, and I think that idea of pain is super important. I actually use that in some of my clinical vignettes when I'm teaching people about libido, because people will come in saying they don't want sex, and we won't get to the fact that it hurts. And so it was great that you brought that up. And what I tell people, when they come in with sexual pain and low libido is, I'm not ignoring your libido, but we cannot do anything for your libido if you have pain with sex. The mechanisms of the brain are designed to make you not want something if it hurts. And so there's no medication I can give that will overpower what happens when something is painful. Right. And so I focus on the pain piece. And this is why sexual medicine is, right, so much of a longer, more patient process than menopause, right? Because I can play with different medications. People are going to get better right away. Whereas with sexual medicine, I got to get your pain under control. And that can take a long time. And then we're going to work on if the libido still isn't there. But if it doesn't hurt and it feels good, usually your libido is going to come back. And oftentimes I'll say that, do you think if you had no pain that sex, you would want it? And they'll oftentimes be like, well, yeah. And I'm like, that's right. That's why we're going to focus on that.
Amazing. I could talk to you for days, Tami. You're just like so full of knowledge. I love it. So, as we start to run a little bit out of time, I'd love to just talk a little bit about the interplay between mood, sleep, hormones, and, how we can support women through midlife. We know that so many women struggle, right, as they go through midlife with their sleep. Sleep sucks. And so they're getting up and they're not sleeping, and then their mood is affected, and then they can't function. How do you help them?
So this is where it gets really tricky to say, is this all hormones? Because can I hormone this away? Right. And so
I love that. I use
there's
that all the time.
there's both a change in hormones that happen, and this is where again I think about progesterone, because it's estrogen is not declining, progesterone is, and so if sleep is really the main issue, I oftentimes will give people natural progesterone, or I'll start there. It does help people fall asleep. To stay asleep, sometimes you have to add some estrogen, but there's really changes in melatonin that are happening also, and so I'll oftentimes have people supplement with melatonin. And then I think about what's going on in their life that could be getting in their way. We, as a society, it's not just midlife women. We are
Oh,
not
yeah.
sleeping enough. And it's
No.
really our screens are doing this to us. There's
Yes.
something happening in our brains that we're doing so much screen time at night that's keeping us from sleeping. And there's lights, we don't think about it, but the charging cables are emitting light. They're in our bedrooms. That light is getting in the way of our sleep. And so that's, what can we do kind of lifestyle wise? And then the biggest thing is I always talk to people about how they're exercising, and nobody wants to hear it. But I always say, most of the complaints that I hear about in midlife, they're not going to be cured, but they will be significantly improved if we move more. And
Yeah.
so thinking about how we can get people to move more, especially earlier in the day, is going to set them up to sleep better. It doesn't make people more tired. It gives them more energy. It's going to improve their libido. It's going to improve all the things they complain about, right? The weight gain, the fatigue, the mood changes, and it really helps with sleep. And when we talk about hormones and neurotransmitters, it's going to help, modulate and help those as well. So I wish I could hormone things away when it comes to sleep, but it's actually much more complicated.
Well, we see that doctors, I know, I remember listening to like an NPR episode or something like that about doctors prescribing people to go outside, right? People are just not going outside. And so just to get some sunlight, to be in nature, that really significantly improving their mood and how they feel. And I thought that was a fantastic idea.
Yeah, I
Um,
think it's, these natural solutions are oftentimes under recommended and underappreciated. People don't appreciate when I talk about those kinds of things, but we have to, right? Because it's true. It's not just anecdote. It's based on science.
Absolutely. So I have a few rapid fire questions for you. So what do you think is the most misunderstood hormone?
Progesterone. I've said it a million times. It really, in OBGYN, it's like only the uterus is protector, and that's just not true. We're using it now to increase seizure threshold rate. It actually decreases your risk of seizures. I'm having patients now come to me with, we didn't talk about the gut, but there's gut motility issues that happen related to progesterone. It actually slows the gut, right? We know that because when people are pregnant, they get constipated. And so there's aspects of it, right, with gut motility, and we see people's digestion change in their luteal phase, and that's because of progesterone. Progesterone is really good in the lungs. It actually helps facilitate breathing and gas exchange. I mean, it's the coolest hormone. And so that's the one that I think is the most misunderstood. And like I said, it's the only one that we are the only people who make, right? XY individuals do not make progesterone, or at least in any measurable quantity. They make it, it's in the pathway towards glucocorticoids, mineralocorticoids, and testosterone, but not its own thing.
I have a newfound respect for progesterone. So, what is your favorite clinical breakthrough?
My favorite clinical breakthrough, I would, I think it's actually, I mean, in the menopause space, it's actually understanding the neurotransmitters that cause hot flashes, right? So the newer drugs are not, they're actually, we always knew that estrogen modulated the thermoregulatory parts of the brain, but there's actually neurotransmitters like kisspeptin and other things. And these are just huge breakthroughs that we can stop guessing, and we can actually say, hey, wait, we know what's causing this, or we know that there's a new molecule and we can target that specifically.
One thing women over 40 should be doing, but often are not.
Exercise. I said it already. We've
I bet
got
you
to
there's.
move more. And so there's two parts of this, right? There's, we talk, everyone's like, well, I'm strength training, I'm protecting my bones. And I'm like, strength training does not get your heart rate up. And so it's really good for you. We lose muscle mass, dramatically once we go through menopause. And so kind of maintaining that muscle mass, it's hard to build it, but maintaining it with strength training, that helps with insulin sensitivity and a lot of health conditions. But that is not going to get your heart and your mood and your sleep and your libido and your skin and all the things that people are complaining about better. Getting your heart rate up will.
Sex after menopause, underrated or overrated?
Underrated. It's so important.
Yeah.
I said this before. It's like I hate the term. We talk about this. The term "use it or lose it" is just an obnoxious term. I don't like that. But I will say that it is, when we talk about vaginal health, we didn't even get into that on this talk,
Yeah.
that sex is extremely good for
That's the
keeping
next
the healthy.
episode with you.
Okay. Sex is, it keeps the vagina very healthy. It's good for your mood. It's good for your relationship. Relationships are hard. The longer people are in them, the more challenging they are. And
Yeah.
so I think that it's, if you don't want, I'm not here to ever tell anybody who's perfectly happy that they don't want sex and it's working out for them that they should be having it. That's not the case. But I think that it's a lot of times I hear people talk about conflicts that they have in their relationship. And again, I don't want to make assumptions, but I'm like, people who have regular sex, they don't have conflicts over stuff like this. These are little things. There's real conflicts out there, but you put up with a lot more, like my grandmother said, if you're having sex. And ideally, the sex is good. I don't want people to be having bad sex. That's not going to make things better.
That's amazing. I always feel like, sex is the barometer of a relationship. And I always feel like, whatever is going on inside of the bedroom is also going on outside of the bedroom, right? So if we're not talking, if we're not speaking to each other in the bedroom, or if we're not able to talk about sex or tell the other person what we like, what we don't like, then we're probably not doing that otherwise.
And it's also a barometer for health, right? And this is where I go to so many male sexual medicine conferences
Yes.
because, as I
Yes.
said, I married a
Sure.
male sexual medicine expert. And
That's
male
right.
sexual medicine is 50 years ahead of us in research, and they are well established that male sexual health is a complete marker and reflective of physical health. It is the exact same for us,
Yeah.
and for women too. And I think that is something that is misunderstood.
Yeah. Yeah. And last thing, best piece of advice you've ever received as a physician?
So this is hard because it's not in menopause. It actually is something I repeat over and over again as a surgeon, and but it applies. And I think about this a lot. I was told that by a surgeon when I was in medical school that he could teach a monkey to operate, but he couldn't teach it who to operate on.
Oh,
And I use that all the time because, we think about this with AI, right? AI is going to take over. What are we doing here? And the truth is, there's something really special about, we might know all the different types of treatments. I know how to operate, right? But when I'm talking to an individual, my goal is to figure out for that particular person what's the right thing for them. right? And that's not something, I mean, maybe eventually AI is going to be able to do that, but that's going to take a really long time because we're all quite unique and quite individual. And so that's really the one I go back to over and over again.
I love it. I love it. It's funny that you remember that. The one thing that I remember from GYN oncologist, when we used to be in the operating room with him, he would say to us, he said, the most important part of surgery, and we'd ask him, "What's that?" And he'd say, "Looking good." I know.
Looking like a true surgeon. It's like, anyways, that's a lot of what they do. I'm not that kind of surgeon, let me tell you.
Yeah, it's so silly. But anyways, well, listen, you are such an amazing podcast guest. I would love to have you on again. You're just filled with knowledge and so fun to talk to that I just absolutely loved our conversation. So for all of those people listening to you and saying, wow, she is so amazing and so compassionate and caring, how can they get in touch with you? How can they get an appointment with you and be on your wait list for the next year and a half?
So I work at UCSF. They can call the UCSF number. It's 415-353-3400. Hopefully not wait too long to get a person. And they can ask for an appointment with me and understand that they may have to be a little bit patient. If people need procedures, they will get expedited because those are a little bit easier to get in for. But for kind of just consults in sexual medicine and menopause, it's a little bit longer of a wait.
So could they just like make it up and just be like, I need a procedure, but then they really don't?
That's not going to go over well. That's not going to go over well. They should just kind of wait. But once you're established, it's a lot easier. So part of the problem with my wait list is that I have a lot more space for follow-up so that my established patients don't have to be waiting for months, but new patients do.
Okay. All right. Well,
thank you
so much. Thank you. Well, we are done here. It's been real and really intimate. And remember, this is not meant to be any type of medical advice. So if you have any questions about your health, make sure you go see your healthcare provider. And until next time, this is the Muslim Sex Podcast. So thank you for listening to the podcast, and make sure you leave us a review, share and like the podcast. And if you leave me a review, I'd love to shout you out on social media. So be sure that you share it with all your friends. And thanks for listening.